Now that we've finished talking about ASCUS and how to manage it, let's now talk about ASC-H. Atypical squamous cells cannot rule out high-grade intraepithelial neoplasm. And we'll also talk about what happens in pregnancy as well and the management steps. So ASC-H, as we mentioned, is atypical squamous cells cannot rule out high-grade squamous intraepithelial lesion. So this is a very major indicator. Remember, high grade is a very serious kind of condition, high risk of cancer. So we cannot treat this the same as we did for ASCUS because of the much higher risk. So like before, we always need to pay attention to what happens in management in different ages of women. So if women are 25 and older, we're going to do a colposcopy. So with ASCUS, we did an HPV test. But now we'll just do a straight colposcopy, skipping all the HPV testing. What if a woman's between 21 and 24? We're also going to do a colposcopy. And why are we doing a colposcopy? The reason why is that we cannot exclude a high-grade intraepithelial lesion, so we need to do something immediately to rule it out. And the best way to rule out a high-grade intraepithelial lesion is to do a colposcopy, which is the scope of the cervix, and we can actually see this intraepithelial lesion using this scope. Now let's see what happens in pregnant women. So we're going to first talk about how pregnant women are managed in the condition of ASCUS. So with ASCUS, if we're going to do a pap smear during pregnancy and find out that it has ASCUS, and the next step is supposed to be colposcopy, that can be deferred to 6 weeks postpartum. So we'll talk about this in the next slide, when you're going to actually have an ASCUS in pregnancy that could lead to a colposcopy, but you don't need a colposcopy with ASCUS in pregnancy. It can be deferred because of the high rate of cancer regression and the low risk of progression as well in pregnant patients. So do not perform endocervical sampling or endometrial sampling. The only time you perform endocervical sampling is if you do it with a soft brush, not a curette. A curette is a very rough way of getting an endocervical sample. So as a result, you could disrupt the cervix and cause a preterm pregnancy. And endometrial sampling is not practical because the cervix is closed. You don't want to open the cervix and go in there and disrupt the pregnancy. So this applies to all pap smears. Do not ever get endocervical sampling with a curette or endometrial sampling. And if a colposcopy is done, only do the cervical biopsy if there's a high-grade lesion present. So you want to save the cervical biopsy for only high-grade lesions because of the risk of the cervical biopsy causing problems to the cervix and leading to an early delivery. Remember, the cervix is closed, preventing the pregnancy from delivering. So if you mess with the cervix or damage the cervix, you could cause it to inadvertently dilate and cause major issues down the line. So only do a biopsy if there's a high-grade lesion present. Now, if ASC-H is on pap smear in a pregnant woman, they're all going to receive a colposcopy no matter what. Remember, a high-grade lesion is very dangerous and very problematic. You don't want that to progress during pregnancy. So if you have an ASC-H, get a colposcopy. So some key points outside of this that we want to talk about. If you see atypical glandular cells on a pap smear, treat it the exact same as ASC-H. Okay, so AGC is atypical glandular cells. Treat it the exact same as ASC-H. So do a colposcopy in management for both pregnant women and for 25 and older and 21 to 24. Now you'll see the term adequate colposcopy here and there. Let's talk about what that is defined as. That means you get full definition and evaluation of the lesion, okay? The lesion is fully evaluated when you do a adequate colposcopy. And in addition, you get a full evaluation of the squamo-columnar junction. So the entire squamo-columnar junction is evaluated, and you can do an endocervical curettage as well with a soft brush. Okay, so you have to look at the squamo-columnar junction. The reason why is that the ectocervix is squamous and the endocervix is columnar, and the transition zone between them is the most common site of cancer formation. So that needs to be evaluated fully to be able to rule out any kind of cervical cancer. Now let's do some more flowcharts and talk about this. This will help make things a lot easier to understand and learn. So all women with ASC-H, atypical squamous cells, cannot rule out high-grade intraepithelial neoplasia, or atypical glandular cells, like we mentioned, always get colposcopy, even if they're pregnant. So always remember this guideline. Next, we're going to repeat this that we looked at before about women 21 to 24 with ASCUS, and we're going to do this for a specific reason. So we talked about in the previous slide about in pregnancy, sometimes an ASCUS can lead to colposcopy. Look right here. This ASCUS can lead to colposcopy. So say a woman's pregnant, has one of these repeat pap smears in 12 months from a previous negative ASCUS or LSIL, and now the guidelines say to get a colposcopy. If it's ASCUS, and you need to give a colposcopy during pregnancy, you don't actually do the colposcopy during pregnancy, you save it for 6 weeks postpartum. So if you get an ascus that leads to colposcopy and normal management, but it's during pregnancy, defer the colposcopy. Very, very important. Next is pregnant women with ascus that are 25 and older. We do reflex HPV testing like usual, and we're going to do colposcopy, defer unto 6 weeks postpartum, and if it's negative, we're going to repeat the PAP and HPV testing in 3 years. So remember, if they have ascus, we're not going to do a colposcopy immediately. Remember, this is another indication for colposcopy. If reflex HPV and ascus positive, defer the colposcopy. Same with the repeat PAP and HPV testing. Ascus is not a major risk factor. It's a small risk factor for cervical cancer, and you don't need to do too much management. So for pregnant women, colposcopy is deferred if after a previous ascus. Key point.